So you guys hear about spasticity in a couple of different lecture series, I believe, throughout the year, as it applies to many of our different patient populations, and also encounter it clinically quite a bit. So historically, I've given this lecture in a Jeopardy format to kind of be more of a review, question and answer. Unfortunately, I couldn't really think of a way to make that work very well in the virtual environment. So what I thought we would do is I'll do a quick overview of kind of the basics of definitions and physiology of muscle contraction, pathophys of spasticity, a little bit of, extra information on how we approach or some unique characteristics of spasticity in the spinal cord injury population, overview of assessment and grading, and then use some case scenarios to highlight different treatment options. So as we go through the cases, I'm not going to try to pull teeth to encourage virtual participation, but try to just on your own, as we're kind of discussing the case scenarios, think actively about what treatment options you might choose or what additional information you'd like for assessment of the patient before we kind of get into that for each case. And I think that would be the most helpful from an educational perspective. So as hopefully you all know at this point, spasticity is defined as velocity dependent increase in tone, and that can include increase in tonic stretch reflexes, exaggerated phasic stretch reflexes or tendon jerks, and clonus. Spasticity is part of the upper motor neuron syndrome, which is a constellation of symptoms seen in upper motor neuron lesions that includes spasticity, hypertonicity, clonus, release of primitive reflexes, possibly dystonia, rigidity, and loss of autonomic control. And the key etiology of this is thought to be the loss of descending facilitation of inhibition on the spinal interneurons, which we'll get into in a little bit more detail. So in general, you have your motor unit, which is comprised of the alpha motor neuron, its axon, and then all of the muscle fibers innervated by that neuron. And when functioning properly, these motor units will fire in coordination of agonist and antagonist systems with kind of classic or normal patterns of recruitment and decruitment of the individual kind of motor units and muscle fibers. And this coordination is accomplished with use of a pretty complex sensory feedback loop that includes information on muscle length, tension, velocity, joint position, and is mediated by a bunch of different reflexes, both monosynaptic immediately, and then some complex higher level control. And these involve the muscle stretch receptors, which carry afferent information regarding that muscle length, tension, position, and velocity, in the spinal interneurons, which are kind of facilitating a lot of these feedback and reflex loops. So your primary muscle stretch receptors are the muscle spindles and the Golgi tendon organs. So the muscle spindles will provide afferent information via group 1A and group 2 nerve fibers. And the muscle spindles are composed of intrafusal fibers, and as such, they primarily will relay information related to muscle lengthening, but they're not activated by muscle shortening or contraction. Whereas the Golgi tendon organs are activated by both lengthening and shortening of the muscle, as they're in series with the extrafusal muscle fibers. And they relay information primarily via group 1B nerve fibers. Then that information will be relayed in coordination with the spinal interneurons, which are kind of like this integration point for that sensory input from your muscle stretch receptors, as well as supraspinal inputs to influence the motor neurons. So there are a bunch of different pathways, but overall the normal result in normal functioning is net inhibition of reflexes at rest. And so some of the kind of primary inhibitory pathways, so you have 1A reciprocal inhibition, which is those 1A afferent fibers will have connection to the alpha motor neuron of synergistic muscles as well as inhibitory or antagonist muscles. And so this inhibition of antagonist muscles with activation of agonists is called reciprocal inhibition. And then 1B non-reciprocal inhibition involves the 1B nerve fibers firing from the Golgi tendon organs, which result in an inhibition of agonist muscle and facilitation of antagonist muscle. So the kind of purpose of that is imposing this sealing effect on muscle contraction to prevent musculotendinous injury. And then Renshaw cells are specific inhibitory interneurons, which have the ability to suppress both alpha and gamma motor neurons via a negative feedback loop that is called recurrent inhibition. So what essentially does is limits 1A reflexes, which reduces agonist activity and facilitates antagonist function. So in a central nervous system lesion, such as spinal cord injury, the loss of supraspinal influences on this baseline interneuron inhibition is thought to exaggerate normal reflexes. So you have loss of normal recruitment and decruitment patterns among the motor units. And then these changes in the spinal interneuron pathways include impairment in normal reciprocal inhibition. So you can end up with co-contraction of antagonist and agonist muscle groups at the same time. You also have decreased presynaptic 1A inhibition, which basically leads to increased excitability and firing of the alpha motor neurons. You have reduction of 1B non-reciprocal inhibition, which leads to loss of that protective negative feedback loop. And then you have this paradoxical actually increase in Renshaw cell inhibition, which just further contributes to the reduction of reciprocal inhibition. So just some kind of general thoughts on spasticity and spinal cord injury specifically. There's kind of a wide range when you look at the epidemiology, but we think up to 78%, possibly more persons with spinal cord injury have spasticity to some degree. It is more common in higher level injuries and typically will develop after resolution of spinal shock phase. And that is also a wide range. So that can be 1 to 3 days as early as or up to 2 to 3 weeks post-injury, and sometimes even further out that patients are starting to develop spasticity. But very often this occurs within the time period that they're in the inpatient rehab unit with us. So oftentimes we're kind of starting management in that phase. Some other things that kind of influence our thoughts about spasticity in patients with spinal cord injury is just like some of the autonomic issues. Spasticity can be exacerbated by noxious stimuli or things that the body doesn't have the ability to perceive normally. So sometimes a patient's spasticity may be significantly increased by an infection such as a UTI, by the development or presence of a pressure wound, by having on clothing that's too tight, being constipated for sure, a number of things. So the purpose of today's lecture is to kind of focus more on spasticity itself and management of that, but it's important to always remember to look for other possible underlying causes, especially if there's a more abrupt change in a patient's degree of spasticity. The other thing to remember when we start to think about creating treatment plans is that spasticity itself is not always harmful to the patient with spinal cord injury, and in some cases may be beneficial. So depending on the patient's level of function, they may be able to use their tone to assist with functional tasks such as you know, kind of triggering a spasm, possibly to help with leg management with a transfer, or even kind of kicking that in to assist with some weight bearing if they have enough functionality to be able to be doing things like supported standing. Other benefits that, you know, we think may hold from spasticity that may not necessarily be functional are things like maintaining a degree of muscle bulk and tone because the muscles are contracting and preventing the atrophy that comes from denervation, as well as having those forces from spasticity on the joints and bones. There's thought that that may help to preserve a degree of bone health, although the data on that is not really 100% convincing either way. So assessment and grading, hopefully most of you are familiar with the Ashworth and modified Ashworth scales, which is, those are the primary things that we use clinically to grade someone's spasticity. The primary difference between the Ashworth and modified Ashworth being the presence of this 1+ grading in the modified Ashworth scale compared with the Ashworth that does not have that 1+. But essentially, you're going to be grading with the modified Ashworth or MAS the patient's resistance or degree of muscle tone to passive range of motion or passive stretch. And so the grading is dependent on the amount of the range of motion under which you will feel resistance, as well as the degree of resistance felt. There is a fair amount of subjectivity in this, and so you know, these definitions are here and we try to be as consistent as possible, but the MAS is known to have fairly poor inter-rater reliability when used in research and such things, so just something to keep in mind. Some other scales that you may see, but are used generally less frequently. This Penn spasm frequency scale you may see in research. I don't necessarily use this formally clinically in terms of giving the patient a grade, but I do think about it and kind of use the principle of it. So this is actually a patient self-report scale, and there's basically a score from 0 to 4 in which the patient describes the frequency of spasms, with 0 being no spasms, 4 being spasms occurring greater than 10 times per hour, and then of course 1 to 3 being kind of specific gradings in between those two. I think this is an important measure because you may see patients who have more of this phasic spasm component as opposed to resting muscle tone. And so they may have low or 0 modified Ashworth scores, but significant Penn spasm frequency scale scores. And so it's actually been shown in some studies looking at both of these that there's not a significant correlation between the two. And so I think it's important to look at both for patients with spasticity because you may not be picking up everything with the modified Ashworth, and you know, have someone coming into clinics talking about how bad their spasms are, and you range them and say, oh, they're not that bad, but you might just not be picking up on more of that phasic spasm component that they have. The Tardo scale, again, is something that's used more commonly in research and, you know, to some degree in the pediatric or cerebral palsy population. But basically, it measures resistance to passive movement at both fast and slow velocities. And there are measures for both the joint angle and the resistance of the muscle. And then there are a couple patient population or diagnosis specific kind of multi-assessment tools. For spinal cord injury, there's one called the Spinal Cord Assessment Tool for Spastic Reflexes, or SCATs, which grades the severity of clonus, degree of flexor spasms, degree of extensor spasms after a movement from a flex position. So just a little bit more factors all combined. Again, those mostly going to be used in the research setting, but just to be aware that these things exist. So we're going to move into some case scenarios, which I essentially just picked some of my own patients, as there are many that could be used as examples, to just discuss some features or highlight some different options or aspects of the management of spasticity. So for case one, we'll say we have a 44-year-old male who has a C4 Asia Impairment Scale B spinal cord injury. He's on your rehab unit. He's about 3 weeks post-injury. Over the preceding couple of days, he's been use bilateral lower extremity and truncal spasms, which he reports are most bothersome at night. They are uncomfortable and interfering with sleep. When you examine him, you'll give him an MAS 1+ score, kind of diffusely throughout the bilateral lower extremity muscle groups. He has some elicited clonus at the bilateral ankles. He's currently on gabapentin for pain and not on any spasticity medications. So when you think about this patient, is there anything else that you'd like to know or want to kind of look into either in your assessment, physical or history, or in his chart? And what would you consider to proceed with treatment? So we'll add, some things you might think about, because we're probably going to be thinking about starting some kind of medication or treatment for this patient. So we'll add that he doesn't have any significant past medical history or concurrent medical problems, as, of course, if you're starting new medications, you want to be thinking about if the patient, is on other medications that may interfere, etc. And we'll say he has no lab abnormalities or other signs concerning for infection or other noxious stimuli. But of course, like we mentioned, that's something that you want to always consider as well when someone's having a change in their spasticity. So at this patient who, is not really on any formal treatments at this point and is just starting to develop tone, we'd probably want to consider things like modalities and therapies and oral medications to start. So stretching, we kind of take for granted in the inpatient rehab setting that obviously therapy is happening for the patient multiple hours a day. So modalities necessary for tone management are happening. But it is important to begin educating the patient and family about the importance of stretching as a modality for tone management moving forward, as it does make a difference and will be important to continue when they go home. So, of course, we pretty much will presume that stretching is happening in therapies. But sometimes I like to remind the patient that if they do, this guy is C4 Asia B, so he's probably not going to be able to stretch himself. If they do have that ability, asking them to do so, or having family or staff educated that maybe, a stretching routine prior to bedtime, especially if nighttime spasms are an issue, can be helpful. And that's something then that, the patient and family can learn to kind of carry forward to whatever their next setting is. As far as medications go, in general, in the spinal cord population, you're usually going to reach for a baclofen first. I think anecdotally, it just seems to have the best effect for spasticity of neurogenic etiology. As a reminder, since this is of course testable, baclofen works as a GABA B agonist, so it's GABA mimetic at the presynaptic and postsynaptic receptors, and as such, it is able to suppress release of excitatory neurotransmitters as well as dampen the effect of these neurotransmitters, given that it has presynaptic and postsynaptic action. Typically, your dosing is TID to QID, and it kind of depends on the patient where you're going to start. But most often, you may start at doses something like 5 to 10 milligrams TID to QID, and then titrate up in similar increments, depending on the patient's tolerance. There are a fair amount of side effects. It's pretty common to have some degree of sedation or mental fogginess with baclofen, and so that's something to counsel the patients about from the beginning, and then to kind of keep a lookout for as you're putting them on this medication. Alternative medication options, just to generate a little bit more of a list. Dantrolene, tizanidine, and diazepam would also be things that you might consider for spasticity management. And we'll end up discussing those in a little while further. So let's say the same patient 2 weeks later, he's continuing on your inpatient rehab unit and continuing with a good stretching program. He's taking baclofen 30 milligrams QID and tolerating it well. And those leg and trunk spasms have improved to more manageable, but he's having increasing tone and some related pain in his bilateral upper limbs now. So he's got an MAS2 at the shoulder adductors and MAS1+ at the triceps bilaterally. So is there something that you would consider adding to his treatment program? Or again, is there anything else that you would want to do at this point, given these new complaints? So of course, again, we're going to rule out underlying causes of increasing spasticity. But again, just kind of moving on to highlight treatment options. I think in terms of medical management at this point, your options would be to consider increasing baclofen further, as he's at 30 QID, which is a fair amount of dosing, but not max. And if he is tolerating it okay, you could consider going up. Another option would be considering use of tizanidine or Xanaflex. So tizanidine, as a reminder, is an alpha-2 agonist. It inhibits excitatory neurotransmitters through the facilitation of glycine. And the reason I'm bringing it up in this case scenario is that there's a lot of anecdotal reports in the spinal cord injury population that tizanidine is thought to better control spasticity in the upper limbs. We really don't know why that's the case, but it's reported by many people and anecdotally does seem to have that effect. So whenever someone is having more of an upper body spasticity issue, we will consider use of it. That's also not to say that it doesn't work in the lower body, and it's also a useful adjuvant or additional therapy, or even solo therapy, depending on someone's baclofen tolerance, for lower extremity spasticity as well. But it's something we definitely think about when someone's having upper limb involvement. Dosing is classically TID. It also can be pretty significantly sedating, as well as have some issues with hypotension. So depending on the patient's presentation, when their spasms are bothersome, what kind of control you're trying to achieve, bedtime dosing is not incorrect and may be helpful. And tizanidine itself, I will sometimes use as a PRN. It does have a little bit of kind of a faster onset, and it gives kind of like this sense of kind of relief of spasm initially. So sometimes people will find it helpful as an as needed. Do you guys have any questions about this case before we move on to the next? Okay. So let's say case 2. This is also someone on your inpatient rehab unit. She's a 72-year-old woman. She has a C6 Asia Impairment Scale C spinal cord injury. She's about 2 weeks post-injury. She is having increased tone in the bilateral lower extremities primarily, which is interfering significantly with hygiene, dressing, and transfers. So the patient herself is complaining about spasms that occur at night, but you're also getting input or having multiple therapists and nurses come up to you, telling you that her tone is so bad that it's causing a lot of difficulty with what they're trying to do in therapy functionally, as well as from a nursing perspective, things like dressing, hygiene, cathing are really difficult due to her lower extremity tone. So she's got an MAS3 at the hip adductors bilaterally, MAS2 at her hamstrings, and MAS1 plus at the ankle plantar flexors. She was started on baclofen 5 milligrams TID, but she states she absolutely cannot tolerate this due to sedation and fogginess. She feels drugged all the time, and she absolutely does not want any other medication that will make her feel drowsy. So what could we do? I think.
Oh, yep, there it is. Okay.
Thank you, Dr. McCoy.
Sorry. Yeah, no, I mean, I was just going to say, check a set of LFTs and you could try dantrolene. Yeah, or you could try non-medication modalities. But yeah, I think that dantrolene's the one that's like the least sedating, but again, there's like always that, I think it's like a 1% chance that it could cause a transaminitis, so it's a good idea to check LFTs.
Exactly. I'm gonna let Dr. McCoy do my lecture for me. He had all the points I was gonna make about dantrolene. So usually when someone's having issues with sedation, or you're worried in advance, maybe outside of the spinal cord population, or someone's a dual diagnosis brain injury, you're already worried about cognitive side effects. Dantrolene has a peripheral mechanism of action by inhibiting calcium release from the sarcoplasmic reticulum, so that's at the level of the muscle. So really it shouldn't have central action. The thing to really remember about it is it has, like Dr. McCoy said, about a 1% incidence of LFT elevation. So you wouldn't want to start it in someone who already has a history of liver disease or who already has a transaminitis, and you'll need to monitor the LFTs as you are titrating the medication. So in the inpatient setting, you're typically going to monitor weekly as you're on this medication. And even in the outpatient setting, they should be monitored at least monthly initially, and then kind of spread out as, if they remain stable. But they do need continued regular LFT monitoring if they continue on this medication. Because of the LFT elevation as well, you typically need to titrate up slowly. So it's generally TID dosing. Max dosing is 100 TID, and that's usually where you need to get to be effective, although some people may have effect at lower doses. And you'll typically start at 25 TID and work your way up. I have had some patients state that they do feel sedated on dantrolene. It's not really clear, as there's not really a mechanism by which that would occur, but it's not unheard of, at least anecdotally in the clinical environment, people do report that, but in general, it shouldn't have a sedating effect compared with the others. The other thing you could do is always try alternative medications if it's really important to try to get this patient's tone under control, which in this scenario it likely is, given that you're hearing from multiple people how much of a barrier it is. So depending on the patient's willingness to try, you're in the inpatient setting, you could always try other medications, even though they might be sedating, as people respond differently to different medications. So sometimes it's a little bit of trial and error, but when you're really worried about sedation, dantrolene is probably the first thing from a medication perspective you want to try. And then again, you're always going to emphasize that there are other modalities to be done to help with tone management, but in the setting of this case, she has pretty significant MAS scores, and it sounds like the tone is a pretty big barrier across the board. So you're likely going to be wanting to try some kind of medical management. The other thing to think about in this case is, if she can't tolerate oral medications, when would you consider something like toxin injections? There's some debate about performing toxin injections early after injury, but it could be done. The other issue I would have is that she has pretty diffuse lower extremity spasticity, so you may not be able to really achieve good control with toxin injections alone. It's usually better if the spasticity is more focal. So we'll move on to the next case. So this is a 19-year-old He has a history of L1, Asia Impairment Scale C spinal cord injury. He is following with you in outpatient clinic. He is a couple of months post-injury. Following his inpatient rehab course, he is ambulatory with the use of bilateral articulated AFOs, and he's currently participating in an outpatient PT program. He has, since he's left the inpatient rehab unit, begun to develop more tone and spasm in the bilateral ankle plantar flexors and inverters, which he states cause painful cramping at night and interfere with sleep, as well as interfering with his ambulation progress in PT. He notes just feeling like his foot's always being pushed down, and in bare feet, he's not able to obtain a foot flattened stance. He has kind of he's on his toes. He can't get his heel all the way down. You also have a note from his physical therapist letting you know that the plantar flexor tone is interfering with his progress otherwise in therapy. He currently takes baclofen 10 milligrams at night. He states it's somewhat helpful, but he still does have a little bit of cramping, and he doesn't want to take it during the day due to mental fogginess. He's a college student, and he doesn't want to be taking medications that will cloud his brain during the day. So what might you consider doing for this patient? So I think this is a great case for neurotoxin injections. So he has focal spasticity, primary the plantar flexors and inverters. So those are specific muscle groups that you can target. And he really doesn't want any mental fogginess, so you don't have any adverse or systemic effects with toxin injections. Generally, you're going to start with onabotulinum toxin A, which is Botox, although there are several other toxin types. As a reminder, the mechanism of action for the A toxins is cleavage of snare proteins at the neuromuscular junction, specifically the SNAP25 for Botox, which then prevents acetylcholine release presynaptically. So I think that, again, this is a good case for the use of neurotoxin injections. In addition to that, is there anything that you might want to consider with regard to his bracing? Of course there is, because I'm asking about it. So you might also, he already uses bilateral AFOs. And so you may want to make sure that they have tone reducing features, and if not, consider having those added in discussion with the orthotist. So tone reducing features in AFOs can include an elongated foot plate, metatarsal bar or pad, an archer and metatarsal supporting foot plate, and possibly setting the toes in slight dorsiflexion. So all of those measures can provide an amount of feedback at sort of like that distal portion of the feedback loops that lead to tone, and by kind of giving pressures in these specific areas, you can reduce tone to some degree. So that would be another kind of an additional option to consider for this patient. Okay, so the next case, so this is a 24-year-old female. She has spastic tetraplegia secondary to a cervical spinal cord lipoma and subsequent cord tethering postoperatively. She follows with you in outpatient clinic. She's been dealing with severe spasms and clonus in the bilateral lower extremities, right greater than left. She's currently managed with oral baclofen 20 TID. She feels pretty decent at that dose, but she doesn't want to go higher due to sedation. And she is getting Q3 month injections of onabotulinum toxin A. She's been getting injections for a couple of years, And she has started noting more recently that she thinks she's not getting the same effect from the Botox injections that she did previously. She's currently at about 500 units total at each injection. And she's inquiring about trying an alternative type of toxin. So things to consider. We use Botox most commonly. It's kind of the most widely available, covered, and the thing that I think we really just clinically have the most familiarity with. But there are other toxin types. So most of the approved toxins are still A-type toxins. So Dysport or abobotulinum toxin A and ZMN incobotulinum toxin A being two of the other more commonly used. There are others not included in this list, but these are kind of the more commonly seen clinically. And then MyoBlock is the 1B toxin, so ribebotulinum toxin B. And that actually acts at a different site at the synaptobrevin complex. There is some support for switching to a different toxin type if there's a concern for resistance. There are reports of patients who develop antibodies to a specific toxin type and no longer respond. And as such, switching toxin types, especially a switch from an A to a B toxin, may solve that issue. In this patient, I don't know that I'm convinced, given the global nature of her spasticity, that we would get a lot of mileage from switch to a different toxin type. But this is a real patient of mine, and we did have this discussion because she really wants to avoid an intrathecal pump given prior surgical complications that she's had. And so we are likely going to pursue trying a different toxin type before we do anything, do any other aggressive measures, just as it's worth a try. I think as a note, most of our neurotoxin injections are performed to some degree off-label or outside of specific FDA approval, whether it's the dosing that we use or the specific muscle groups injected. But most of the other toxin types have specific indications in cervical dystonia, some for things like sialorrhea, and are not necessarily considered FDA approved for spasticity after spinal cord injury. However, you can usually achieve some approval for the use of them with insurance. So this next case, we have a 31-year-old. He has T6 Asian impairment score A paraplegia. He's 6 months post-injury, following with you in outpatient clinic. He has severe bilateral lower extremity and truncal spasms. He gives his pen spasm frequency score of 4, spasms greater than 10 times per hour, and he says all day and night long pretty constantly. Currently, he's on baclofen 60 milligrams POQID, tizanidine 6 milligrams TID. He's also on max dose Lyrica for neuropathic pain, and he also uses medical marijuana. He states that he does have drowsiness and mental fogginess at these doses in combination of medications, but that he deals with that because of the severity of his spasms with medications and even worse without medications. So what would you consider for this patient? So this is a good setup for an intrathecal baclofen pump. Again, at 6 months post-injury, it's a little bit early, and there's some suggestion of waiting a year just given pending recoveries. But this guy's Asia A, and he's having really severe spasticity that is already poorly managed on nearly maxed out medications. So it wouldn't be unreasonable to consider sooner rather than later. So the first step would be an intrathecal baclofen trial. So that's traditionally performed as a bolus dose under fluoroscopy guidance, usually with assistance from our pain management colleagues. Starting dose for a trial is typically a 50 microgram bolus, and then 100 microgram bolus could be used for a second trial if effects were not significant or what you'd like to see with the 50. Not at most institutions, but here at UPMC, we do also have the option. There's a program at Presby with Dr. Musi where you can have a continuous intrathecal baclofen trial, where basically they will place a catheter and do more of a continuous drip rather than a bolus to allow the patient to try things out more over a prolonged period, which kind of simulates more so the way that the pump would deliver medication. I usually reserve that option for patients who you're not really sure how they're going to respond to having the intrathecal. Usually people who are maybe using their tone to some degree functionally, especially people who are ambulatory, you know, and maybe worried that taking their tone away is going to interfere with that. Otherwise, it's usually, and I think in the case of this patient, doing the standard bolus trial is perfectly sufficient. Other considerations for pump placement and things that you would discuss with the patient, risks and benefits. Obviously, the benefit is hopefully better spasticity control and ability to reduce or eliminate oral medications, and as such, reducing or eliminating all those cognitive drowsiness side effects. Risks, of course, are that you're having a surgery and having an implantable device. So there are always risks of infection as well as complication of the device itself, catheter break, pump malfunction, etc., which can then lead to risks of baclofen withdrawal or overdose. So it's important to educate the patient on those up front and then continually after they get the pump placed so that they can be aware of, you know, any warning signs or symptoms. Other things to consider prior to pump placement is compliance of the patient. So it's not really a good idea to recommend this for someone who is non-compliant with follow-up visits or with medications, or, you know, just has issues with communication in general, as then you would have safety concerns. And then the lastly is catheter placement. So typically you want to be able to place the catheter kind of above the injury level as much as possible in order to try to have the most action on kind of where their tone is. So usually you'll just, you know, want to make that recommendation. Like if the patient is a T6 level and he does have truncal and lower extremity spasms, you would like the catheter to be placed above T6. And so this can come into play if you have higher level cervical injuries, especially if their tone is primarily more in the upper limbs. You may not be able to achieve as much effect from an intrathecal pump as for the lower parts of the body. So we'll say that we're considering, you know, we're going to set this patient up for an intrathecal baclofen trial. He's also planning to resume his outpatient PT program, and he wants to know if there's anything he could do in PT to also help with his tone. So in addition to stretching, are there any other things that you would like to see included in his PT program that might help with his tone management? So there are some other things that may help. So in someone who is otherwise medically appropriate for supported standing, a standing frame can be really beneficial, both in the therapy setting and, if possible, for the patient to obtain one for home use. There are a lot of supposed benefits to supported standing, but from a tone perspective, doing a supported stand in someone who otherwise doesn't stand at all gives a great prolonged stretch, as well as a little bit of weight bearing feedback, both of which can really improve tone. This specific patient actually did start using a standing frame in outpatient therapy, and he noted that he had significant relief from his spasms for several hours after his therapy sessions when he used the standing frame. Now, of course, it's not permanent lasting effects and needs to be upkept. So again, trying to get, if this is something that's helpful for the patients, trying to pursue getting them to obtain one for home use if it's something that they're able to use in the home can be helpful. Other things that may help, electrical stimulation, especially use of an FES spike has been thought to or shown to some degree to have improvement in tone. Again, it's usually pretty short-lived. The patient will usually have, improvement in spasms or reduction in tone for maybe up to a few hours after use of this in therapy before they kind of return to their baseline. But it does give some relief, although not necessarily a long-term benefit. FES spikes are also able to be obtained for home use, but very expensive and much less often covered by insurance. So usually someone is using that in the therapy setting. And then other modalities with therapy or at home that may be helpful, again, at least that sort of, giving a little bit of short-lived relief from spasm or tone, heat, cold, use of vibration or massage, use of therapeutic ultrasound. So all additional things you could think of on top of, medication or other interventions for spasticity management. So that is all I have for cases. A couple of final points that, I didn't put in the slides or didn't fully discuss that I just want to mention. One is that spasticity does not always need to be treated. Obviously, for the purposes of this lecture, we focused on spasticity that did necessitate treatment. But as we mentioned, it can have some benefits. And if it's developing and not bothering the patient, it doesn't necessarily, need to be intervened upon. So just something to keep in mind. And then there are a couple of treatment options that I didn't really mention fully. One being benzodiazepines, specifically Valium is the most commonly of that class used for spasticity management. Actually pretty good spasticity reduction medication, but pretty bad in terms of side effects. And then, being controlled substance in general is just kind of less favorable for use, as well as especially people in the initial post-acute period. If they're also on opioids for pain management, you want to avoid combining that with benzodiazepines. But just to know that that's out there. And then lastly, I did mention, in one of the cases that the patient was using medical marijuana, it just remains one of those big question marks in terms of an ongoing need for more data to truly demonstrate the degree of efficacy for spasticity or any other symptom management. But it is something patients ask about, and I have a fair number of outpatients who have pursued getting their medical marijuana cards and using it for treatment. I have yet to have a patient who is only using medical marijuana and has come off of all their other medications or not pursued Botox or baclofen pump, etc. But it is out there as an option, and so it's it's just another thing to offer or educate patients on in the realm of treatment options.
Hey, Dr. Berry, I had a question.
Yeah.
So with the patient that you described that was on like max doses of baclofen and tizanidine, so after such a patient gets an intrathecal baclofen pump, how do you go about like weaning off or decreasing other medications? Do you kind of have a strategy that you use, or?
Yeah, that's a great question. There's not necessarily a formula, but usually you just kind of do it in a stepwise fashion. It's most ideal to be able to bring people into the inpatient rehab setting after a pump placement so that you can titrate more quickly in terms of increasing the pump itself and stepping down the oral meds. So usually I'll start with cutting off the oral baclofen before, if they're on other medications such as tizanidine, because obviously you're giving them back. And then if their spasticity is well controlled, usually you can work on coming off of some of the other meds as well. If they are someone that has, some upper extremity involvement, sometimes they'll stay on some degree of tizanidine to help with that, as the pump isn't quite as effective for upper limb tone. But in general, it's just kind of a cross titration. So I'll just step them down as I'm stepping up the pump. And then when you're kind of choosing your initial pump dose, it's partially, usually the general rule is you can do the bolus dose over a 24-hour period, or you can go up to double that bolus over a 24-hour period based on the patient's response to their trial.
Gotcha. Thank you.
Yeah. Does anybody have any other questions?